Hello, welcome to this session of Health Research Fundamentals. Today we are going to talk about validity in epidemiological studies. Well, what if you come across one day a headline in the newspaper that a study says that coffee drinking doubles the risk of heart attack? What's going to be your reaction? Well, in order to further go in depth into this study, we will actually need to look at how this study was done and how valid are the results of this study. If we look at any epidemiological study, the basic goal of any epidemiological study is twofold. One is to obtain an accurate estimate of whatever is being studied, whether that is the frequency of a disease or the effect of an exposure on a health outcome. And all of this we study in a certain sample of the population. Now, this aspect of any epidemiological study is known as internal validity of the study. How valid are the methodology that is being used to either estimate the frequency or determine the effect of an exposure. Now, in the long run, what we would want is we want that this estimate is generalizable to the relevant target population among which the study is being done. Now, this aspect of any epidemiological study is known as external validity, so that the results of the study can be extrapolated to the whole population. When we talk of accuracy of the estimate, what accuracy actually means, it consists of two things: precision and validity. If we look at say a bullseye and we want to hit the mark, what we would want to be is to be precise and as well as valid, so that we try to hit the bull's mark as many times as possible. So, similarly every epidemiological study can have results which are both precise and valid, which is what we would actually want in every study. However, there could be studies where the results may be precise, which means that every time the study has been done you get the similar results, but it may be that the methodology was not correct and so they are not valid. It may happen that the results are not precise, but sometimes they may be valid, or in the worst case scenario the results may be neither precise nor valid. So, when we are looking at any epidemiological study, we need to be wary of both precision as well as validity. As I told you, in epidemiological studies all that we are doing is basically estimating. We are estimating either the frequency of a disease or a health outcome, or we are estimating what is the effect of an exposure on an outcome. Now, when we are doing these estimations, there are bound to be errors that may happen in our studies. There are two kinds of errors that we come across when we are doing epidemiological studies. One are called random errors, or errors that happen due to chance, which is basically the variability because of any unknown or uncontrollable causes, such as errors in sampling or errors in doing measurements. However, the more problematic error that we may face in any study are called systematic errors or biases. These are the errors that are basically a threat to the validity of any epidemiological study. And how do these errors happen in any study? Basically, the way we do the study, the methodology that we use to do an epidemiological study, and if it is done in a certain way that tends to produce results that are not the true results, then that leads to errors which are called biases, and ultimately what we would see is that either the estimates or the associations that we are trying to assess between the exposure and the outcome in the study sample may differ from the true causal association between the same exposure and outcome that may be there in the source population. So, let us look at the various kinds of biases or threats to validity in epidemiological studies. There are essentially three kinds of biases that may occur in any epidemiological study. These are called as selection bias, information bias, and confounding. So, let us go through one by one. Coming to selection bias. Selection bias happens when we use procedures to select populations. Remember that in an epidemiological study, we are sampling a certain number of individuals to participate in the study. The way in which we select these study participants, are we sure that these study participants really accurately represent the target population? And if there is any issue in which the way we select these people, that results into what we call as selection bias. Now, how do all these things happen in epidemiological studies? Remember that we are selecting our cases and controls, and these may happen through either we are using a surveillance mechanism from which there is a systematic notification of cases, and if we are taking more of exposed cases from the surveillance mechanism, that could be one way in which selection bias could occur. We may be screening and doing diagnosis more systematically among those who are exposed if we know their exposure history beforehand, and then that can artificially create biases. Again, selection biases can occur if we select our cases and controls from healthcare facilities, hospitals, and where if it is likely that more of the case patients who are exposed are admitted or the other way around, that can lead to selection bias. Another common way in which selection bias occurs is when we select those cases who are alive. The cases of the disease who are dead would not be part of our studies, and it may be that the reason why these cases are alive may have to do with the exposure status, and hence selective selection of survived patients can actually lead to selection bias. In cohort studies, selection bias usually occurs when there is a loss to follow. Remember that we have to follow up people over a period of time in cohort studies, and if it's likely that people who are less exposed or more exposed, they are more likely to be lost, or people who are at more risk or are lesser risk, if they are more likely to be lost to follow up, that eventually can lead to results that are biased, and that would be attributable to selection bias. How do we deal with selection bias? We can deal with selection bias at any stage of our study. Ideally, we would want to make sure that the way in which we design the study is free from selection bias. So, one way would be to use incident cases and not prevalent cases, because prevalent cases have the issue of survival bias. Especially case control studies are more prone to this to selection bias, and various ways in which to deal with selection bias in case control studies is to use population based design rather than hospital based design, such that the cases and controls are actually selected from the community or the population and not from few or a particular healthcare facilities. We need to make sure that we apply the same eligible criteria when we are selecting cases and controls, and we are not leaning towards a particular exposure among the cases and controls. Again, both the cases and controls should undergo the same diagnostic procedures and the same intensity of surveillance in order to identify them as cases and controls, so that we are not biased in the time of their selection. Now, at the time of data collection, what we need to ensure is to minimize non-response, to minimize non-participation, and make sure that we do not lose many people, especially in cohort studies over a long follow-up period. Even if we should anticipate actually that we may lose people, and so it would be a good idea to actually keep a record of all these losses, people, at least some basic socio-demographic characteristics of these people, so that later on at the analysis stage we can actually compare people who were lost to follow up versus those who remained in the study, and see if there were any major differences in these two populations which could lead to selection bias. We also need to make sure at the time of data collection that the diagnosis of disease is not affected by the exposure status, which means at the time of selecting who the cases and controls are, the person who is selecting the cases and controls should not be aware of what the exposure status of this population of the cases and controls are, and this one way in which we do this is called blinding. Now, even at the analysis stage, if what we can do is, as I told you before, we can compare those who responded or to those who did not respond, those who were dropouts compared to those who were left in the study with respect to the baseline variables, and see if there are any large or small differences between these two groups. If we find large differences, it is suggestive of selection bias. However, small differences do not rule out selection bias. So, we need to be wary of that. Again, another way to assess whether there may be a selection bias may have occurred in our study is to do what we call as sensitivity analysis, in which we try to do an analysis assuming how much bias could have happened and what direction it could have gone, and try to see how it affects the study results. If the study results are affected in a major way, then we can assume that yes, selection bias has occurred. Moving on to the next threat to validity, and that is called information bias. Information bias is essentially a bias that can occur when we are measuring the characteristics of study participants. Now, what do we measure? We measure exposures, we measure outcomes, and we measure other variables which may influence the exposures and the outcomes, which are called as third factors or confounders or modifiers. What we need to make sure that the measurements that we are doing accurately represent what it actually is. The level of exposure is accurately measured, whether there is an outcome present or absent is accurately measured, and other variables such as socio-demographic, age, gender, other education, income, all those variables are also appropriately measured. Now, how does this happen? Now, in case control studies, information bias can happen if we are collecting exposure information which is leaning towards a particular exposure status. If we are trying to collect more of people who are exposed compared to the unexposed, or the other way around, this can lead to information bias. One of the very common ways in which information bias occurs in case control studies is through the process of recall. Remember that we have cases and controls, and we are trying to we are asking them to recall the past history of exposures. And it may so happen that those people who are diseased or who have a certain health event may be more likely to recall certain exposures compared to those people who are healthy, and this is what we call as recall bias. It may also be possible that better exposure data is available on cases compared to the controls, and that again can lead to information bias. In cohort studies, information bias can happen if we collect information leaning towards a specific outcome status. If we follow the exposed population much more rigorously compared to the unexposed population, that is something that can lead to information bias in cohort studies. It may also be possible that better outcome data is available among the exposed and then again compared to the unexposed, which can again produce information bias in the study. Information bias can be introduced in a study both either by what the investigator does in the way in which the investigators collect the information about the cases, about the controls, about the exposure, about the whether they get the disease or not get the disease, and if there is a systematic way in which this is being done irregularly, that can lead to information bias. And last but not the least, of course, remember that in observational epidemiological studies, we are dependent on what our study participants tell us, and if there is any systematic distortion of the true facts by the study participants, that is anyways going to lead to information bias. Now, how do we deal with information bias? First of all, because we are measuring the exposure variable, the outcome variable and the other variables, we need to set up precise operational definitions of what we are going to measure and how much is it going to be. We need to have detailed measurement protocols in the way we are going to measure each of these variables. Sometimes it is also a good way to do repeated measurements on key variables, say for example blood pressure, and we know that blood pressure can vary from time to time. So, we may take more than one readings of blood pressures and then take an average of that reading in order to say what the actual blood pressure of that individual is at that particular point of time. It is very important that the investigators are trained and certified in the way in which they follow the study protocol and all the methodology that needs to be done to collect information. We can do data audits both of the interviewers and of course of the data management centers where the data is stored, in order to make sure that the way in which the data is collected, the data is retrieved, the data is stored is done correctly, and there is no information bias happening because of the same. Once the data is collected, we need to make sure that the data is cleaned. We need to go through the data both visually as well as maybe through computer programs, softwares, and make sure that we are getting clean data. It is also good practice to actually rerun all your analysis before you are trying to send your paper for publication, just to make sure that you are not that there is no possibility of any information bias occurring because of the way the analysis was done. Now we are going to look at the next threat to validity, which is called confounding. Confounding comes from a French word which actually means confusion of effects. Now, what effects are we talking about here? Remember, what we are doing in epidemiological study is looking at the effect of an exposure on the outcome, whether if you are more exposed, are you more likely to get the disease or vice versa. Now, what we want to know is the effect of this exposure on a particular outcome. Now, this effect can be confused with the effect of a third factor, which can have an influence both on the outcome as well as the exposure, and this is what leads to the phenomenon of what is called confounding. Now, what does confounding do? Actually, confounding is probably the biggest threat to validity in any epidemiological study, because confounding can actually can show you an association even when it does not exist. Confounding may hide an association that is actually there, or confounding may actually increase or decrease the strength of the association. So, you may say that an exposure is more associated with the outcome or less associated with the outcome than what it actually is. And in the worst case scenario, confounding can actually change the direction of an effect. If an exposure, say, causes an outcome, because of confounding, you may see that the exposure is preventing the occurrence of that outcome, and that is the most dangerous threat to validity in any epidemiological study. So, how does confounding happen? So, diagrammatically, what we represent, that confounder is a third factor, is a variable which influences both the exposure and the outcome. And when we are trying to determine what is the association between the exposure and outcome, this association is influenced by this third factor. Now, we can deal with confounding both at the design stage and at the analysis stage. It is always better to deal it with the design stage than to take care of the analysis stage. So, at the design stage, we can do several things. One, we can do what is called restriction. We can restrict our study participants to only those people who are in one stratum of the confounder, so that the confounder cannot play a role in the association between exposure and outcome. Secondly, we can do what is called matching. If we already know what the potential confounders could be in a particular study, we can match our cases and controls on those particular confounders, and which will negate the effect of the confounder, and then the association that we see between the exposure and outcome would be without the influence of the confounder. Of course, remember that if you do matching, you have to do what is called matched analysis. In experimental studies, we do what is called randomization, and that is something that actually automatically takes care of the confounders and make sure that the two arms in a randomized trials are similar in all ways in terms of the confounding variable. Now, at the time of analysis, what we can do what we need to do in every study is to actually first test whether there is any confounding, or whether there are variables which could be acting as confounders, which need to be taken care of at the time of analysis. And this is where we do what is called stratified analysis, and we stratify our data in various stratum of the confounder, and then try to find associations, and which helps us to identify whether there is confounding or not. Now, in order to take care of these confounders, we can do what is called a multivariate analysis, wherein we use regression techniques, whether it is logistic regression, linear regression, or other advanced methodologies, in order to take into account the effect of confounding, and then the associations that we get between the exposure and outcome are without the influence of the confounder, or as we say, adjusted for the confounders. So, how do you evaluate associations? Whenever you see a study, when you see a risk ratio or an odds ratio, what you see is a crude association. Now, how do we make sure that this crude association is actually the true or the causal association, that is the true relationship between the exposure and the outcome? What we need to make sure is we need to go through this spiral. We need to make sure that it's not because of chance. We need to ensure that there's no selection bias. We need to check if there could be any information bias. We need to understand if there could be confounding and if that confounding has been taken care of. Only after going through this process, we would be able to say that whether the crude association is actually the causal association or not. So, coming back to our problem, does coffee really increase the risk of heart attack? Well, let us analyze this. What we wanted to do is to look at all adults in the population who are drinking coffee. Now, in the study, what we get is a sample of people who agreed to take part in the study. Now, these people could be more people who are more likely to drink coffee or less likely to drink coffee. These people may be hospitalized patients, and if we are doing a study in a hospital, and it may be that these patients are hospitalized for say gastric ulcer, and that's because of coffee drinking. So, the way in which we select these participants can actually lead to a bias, and that's what is called selection bias. Now, the exposure that we are trying to assess here is the actual coffee intake of the study participants, and what we get from the study participants is actually what they report. Are they reporting the true coffee intake? Do they actually remember how many cups of coffee they have had in the past? What's the average number of coffee they drink? Whether they drink coffee with milk, without milk, what's the strength of the coffee? All of these issues can actually influence whether the coffee intake that we are measuring is actually the true coffee intake, and that can lead to information bias. Again, remember that we are also trying to see whether the people really had a heart attack or not. And it's possible that there may have been a misdiagnosis of a heart attack. There could be the chest pain that the study participants may report as heart attack may actually have been maybe due to other causes, and that is reported as heart attack. So, actually what we may be seeing is not heart attack, but some other causes for chest pain, and that's again the study results would then be influenced by information bias. And then of course, there is confounding. Could it be that this association that we saw between coffee and heart attack, what we call myocardial infarction in medical terminology, could it be confounded by smoking? Is it possible that we know that those who are smokers are more likely is a known risk factor for heart attack. It's also known that those who are smokers are more likely to be coffee drinkers, and it's possible that because we may see more of smokers among the coffee drinkers and more of smokers among those who had a heart attack, the association that we are seeing between coffee and heart attack is not due to the actual coffee, but it's actually because of the effect of smoking on heart attack. And so, the results of this association between coffee and MI could have just been confounded by the effect of smoking. So, what we need to understand is that there are various threats to validity in any epidemiological study, and these biases can occur in all epidemiological studies, more so in observational studies such as case control and cohort studies, and less so in randomized trials. Biases can occur during all stages of the study. When we are designing the study, if the study is not designed appropriately, if the study is not conducted appropriately, or if the analysis is not done appropriately, all of which can lead to one or the other biases. And we know that biases threaten both the internal and external validity. Remember that a study which has no internal validity cannot be generalized, and so it does not have any external validity. So, what do we need to keep in mind is that when we are designing a research study, we need to be thinking of all the possible ways in which these various biases could creep into our study, and design it appropriately and try to prevent as many biases as possible at the time of designing and implementing the study. However, we should also remember that there could be some biases which cannot be avoided. What we need to understand is at the time of analysis of the results, we need to be aware of what these biases could have been and state these biases in the form of limitations of the study. So, it is critical that whenever we look at the results of any epidemiological study, we need to be wary of what possible threats could be to the validity of these studies and make sure that the investigators have taken care of these various threats. Thank you.